Hi, everyone. All right. I think we will just wait one more minute and then we'll get started. I will begin to share my screen. Con su permiso. All right. I think you've gotten a PDF of this document if you're not able to see my screen. So you can just check your email. And welcome. It's been a couple of weeks, but we had lots of things happen. So lots of updates related to our COVID response. Like I said, I'm going to just go through the notes that you already have with just very minor differences. And we'll have lots of time to have a discussion at the end. So just to start with the status of what's going on with our numbers, as you can see, we are still experiencing a nice resolution to the Omicron surge, and have hit somewhat of a low plateau. Although it looks like things are leveling off in terms of the decline. So we may be just kind of in a holding pattern, I guess is the best way to interpret what's going on. Hopefully all of you are getting to rest and recharge, at least from COVID work. I know everything else is taking lots of your time, but hopefully you've been able to rest and recharge just related to COVID. Sorry, I didn't realize I wasn't sharing my screen. Okay. In terms of what's going on with the hospitalizations, that's shown on this figure here. As you can see, we still have 64 hospitalized individuals in our county hospitals, and that appears to be leveling off as well. Hopefully, it will continue to go down. We're still pretty high statewide. We're like number 6 in the state. In terms of how many actual patients we have in our hospitals. So that is just something to keep in mind. Another thing that we are going to report, and a press release should be coming out soon, is that we actually have flu still circulating, even though flu should be over by now. The official end of flu season is the end of March. And yet some of you have shared with us, and we pick up on our epidemiology surveillance that influenza activity is still actually causing people to be hospitalized. And we actually had a flu fatality, our very first one of the season, just last week, right at the tail end of flu season. So the bottom line is you should continue to test people if they are symptomatic and fit the picture of influenza. And then obviously encourage isolation regardless of whether it's influenza or COVID or some other viral respiratory illness. Hopefully that is abundantly clear after 2 years of this pandemic that people should stay home if they're sick. But just remember to think about flu while you're thinking about COVID and how they present, because they look so similar in their presentations. What's going on with the variants? Well, all sources point to the fact that this BA.2 variant, perhaps called the stealth Omicron, is now really dominating over the original Omicron variant. It might be 60 to 70% of sampled cases. So this is a nice graph from the CDC. Hopefully you can make out what's going on here. I'll go through the colors. So the Delta variant is shown here in orange. Then the purple is the Omicron variant. And as you can see, the Omicron really took over the new year and stayed very dominant until this new variant shown in the pink called the BA.2 really started to take off in mid to late February. And now this BA.2 variant is dominating even over the original Omicron variant to where it may be 60 to 80%. I put 60% as a conservative estimate, but it may be even higher in some jurisdictions. That's what, LA is reporting. That's what some of our other neighboring counties are reporting. We're not really doing enough whole genome sequencing in Fresno County to have a great idea of how much our BA.2 variant rates are, but we're assuming that it's basically in line with what we're seeing here, which is that it's slowly but surely taking over as the dominant variant. And that has some implications for our therapies, which I'll explain a little bit later. So hopefully that answers your questions about variants. These variants continue to be described because they continue to form inside of infected patients. There's a new variant called XE variant, and this is another subtype of Omicron. Some people have described it as a Frankenstein's monster with combination of the BA.1 and the BA.2, which are the two original Omicron variants coming together. And this XE variant is 10% more transmissible than even the BA.2, which was supposed to be the most transmissible COVID variant ever. So, I'm not sure what to do about it. It's never been described yet in the US, but it is being seen in other countries. I'm sure it's just a matter of time before it starts showing up in the US, but you might see some headlines about the XE variant. I linked to some Kaiser Health News headlines about this variant in other countries. Wastewater surveillance, we were being told that the numbers keep declining, and that's absolutely true. If you want more information about that, then reach out to me. I didn't have space to add our wastewater numbers, but they're really trending well along with this graph on page 1, which is that the numbers are coming down in the wastewater surveillance, and that's nice to know. What are national and state and local agencies doing to support COVID response? Well, just to catch everybody up, we are still working in multiple different avenues on education, vaccinations, testing, therapeutics, and Q&I guidance. And all of those links are provided for you here in question number 2. And I won't belabor all of these links today, but just keep in mind that, this is something that is still taking up a lot of time at the state and local level. We're trying to create media toolkits and educational outreach for our vulnerable populations, especially for the young children that are now eligible for vaccinations, because they seem to be lagging a little bit or a lot in terms of how they're getting vaccinated. There's obviously a lot of myth and misinformation out there about the safety of vaccines that we continue to work against. And so we're just doing what we can to provide good information to folks so that they can make the decision to go ahead and get the vaccine, which is still effective despite all this talk about variants. They're still very effective, and they're still going to protect our youngest, starting at 5 and over, and probably even younger than that very soon, from the COVID infections that are circulating at low levels, but nonetheless circulating in our community. Vaccinations continue to be available at multiple locations. Testing is still free and available, so we know that there's some discussion at the federal level about what's going to happen with COVID response and support. Just keep in mind that that hasn't really percolated down into the local policies or resources at this point. So testing is still free and available at the usual Optum Serve sites as well as pharmacy sites, and all of that is found on the My Turn app, which has been going strong for over a year. The therapeutics locator, which just keeps getting better and better, is run by the feds. And this really is the test to treat program that you've probably also heard of. And that's linked to you on this link website. It's run by HHS, and it's basically shows you where people can get tested and also where they can get treatments at participating pharmacies and clinics. And lastly, this is something that's not in your PDF because I just added it. But the CDPH has actually changed the quarantine and isolation guidance for the general public. In general, it's been loosened, so people no longer are directed to quarantine. They can actually just go about their day and have their daily activities. They're just directed to get a test on day 5 or later if they are a close contact. Now, this is for the general public that's doing low risk activities. For those that are in high risk activities or high risk settings, such as congregate settings, et cetera, they're going to be asked to continue to quarantine. And that is laid out in this guidance, which I linked at the bottom of this page. So what I'll probably do is resend these notes with these updates, because I think it's important for people to know. This does not change how we approach quarantine and isolation guidance with healthcare workers. That's a big bold letters. This does not apply to healthcare workers. This is only for the general public. All right, any questions with that? Just moving on to, how can we all help? So that was the agency response. How can all of us, just as medical providers and part of the medical community, be part of the response? I think this is a really good time for everyone to get better prepared and do reflection as well as preparation for what might come next. If you're a primary care provider or a pediatrician, you really should be talking to your patients about getting vaccinated and boosted. They have questions and they want to listen to you. They trust you. They want to have this conversation, even if they don't come in as their chief complaint about vaccinations, et cetera. They really appreciate you taking 2 to 5 minutes of your time to explain the science of vaccines, to explain how safe and effective they are, and to really urge them and guide them to getting their vaccines and their boosters. It's a super important conversation that all of us should be having, especially now that we have a little bit of time and a little bit of breathing room to have these conversations and point people in the right direction. All clinicians who are caring for immunocompromised patients, I need you to figure out how to get Evusheld for your patients. I'm not really sure what more to do. We've had Evusheld, which is a long-acting antibody, available for several months now. And week after week, we're actually turning away hundreds of doses of Evusheld, usually 200 doses a week, because not enough demand is being shown by our county providers. And I think that that's really disappointing. We have 30,000 immunocompromised patients. We need to get this out. We haven't delivered even close to that number of Evusheld for these patients. If you don't know what it is, or if you need more information about it, the bottom of this document has all of that, or you could just contact us. This is an antibody that lasts for 6 months. It's indicated for anyone with an immunocompromised condition. That means your chemotherapy patients. That means all of your autoimmune disease patients that are on immunosuppressants. That means all of your transplant patients. It's going to protect them for 6 months at a time. It's indicated because we know vaccines don't work. We just have a real disconnect between the people who have all of the supply, which is the health department and our partnering agencies, and the people that know about the patients that need them. We really need to work together to get this into patient arms, because it's not doing any good sitting on the shelves of our hospitals and our clinics. So please, please help me figure out how to get Evusheld into our patients. I know that it requires a couple of hoops to jump through, including the HPOP registration site. That's really not insurmountable. It's really worth it if you're seeing immunocompromised patients to figure out how to get them this medication. It might be as easy as just sending them to the COVID Equity Project or one of the other participating partners that's already providing Evusheld. We just need to be doing a better job with this, because week after week, we're turning away 200 doses. And at the same time, we've got a lot of people walking around who don't have immunity because they're immunocompromised. In terms of emergency departments and urgent cares, again, this is something that we do debriefs after disasters and surges quite a lot. So I think this is the time to be doing debriefing, reflection, and then also refining our processes so that we can be better prepared for the next surge, which inevitably will come. Hopefully it's a gentle surge. Hopefully it's just an uptick, not an overwhelming, catastrophic situation, but we need to be prepared for things looking worse in the future. And so our emergency departments and urgent cares, this is a good time to review policies in anticipation for increased cases in the future. If you're working or overseeing nursing home and residential facilities, please maintain those visitation policies. We know that it might be a little bit of a hardship because that's not how things used to be, but they're super important to prevent outbreaks in our nursing homes and our residential facilities. At the same time, we need to also make sure that our elderly and higher risk patients are up to date on their vaccinations and boosters, which might mean, hosting a vaccination event or planning something where you can do mass vaccinations for those patients. But this is really a time to make sure that waning immunity does not lead to outbreaks because we know immunity might wane in 4 to 6 months after your last shot, which is why new booster recommendations for second boosters have come out from the FDA and have been also supported by the CDPH. And I'll talk more about boosters in a little bit. So I've been asked to talk about PPE and masking in healthcare settings in the hopes that I could basically snap my fingers and make all of these restrictions go away. And unfortunately, I really can't find anything that will make a strong move to liberalizing what the Cal OSHA regulations say related to aerosol transmissible disease standards. And so I pulled up language from AFLs, which are about 6 to 8 months old, but I linked them here just for your reference about this is what is actually required for healthcare facilities. So you do have to comply with the aerosol transmissible disease standard, but I think you are given a little bit of leeway about who needs N95s versus surgical masks. So I think everyone is aware that you have to have surgical masks whenever people are working in a clinical area. And an N95 is required whenever you have higher risk settings, meaning, for example, the emergency department where you could have just COVID patients that are undeclared or undiagnosed that might be transmitting COVID. And so you need to protect your workers with a higher standard. And so an N95 makes sense there. Eye protection makes sense there as well. In other settings where patients have been ruled out for COVID, then you can get by with surgical masks, which are a little bit more comfortable, but less protective than N95s. Beyond that, I wasn't able to find a specific language related to eye protection. I think it makes sense to use eye protection bundled with N95s so that whenever you have a patient who's symptomatic or known to have COVID, they really require the workers around them require full protection with eye protection and N95s. I think outside of that, you can really get by without eye protection as long as you have low risk settings, meaning negative COVID or asymptomatic patients who are just there for non-COVID related issues where eye protection is not necessarily required. I have to tell you, I looked really hard for specific language related to goggles and eye protection because it is so stressed in my emergency department, and I'm sure in other emergency departments as well, but it's really hard to find where that's written down. But it just makes sense that, you know, whenever you're talking about aerosol transmissible diseases, that eye protection is part of the full PPE that's required for those workers. So hopefully that makes sense. I basically pulled a text box from one of these AFLs, but I would also check the aerosol transmissible disease standard, which is a Cal OSHA code of regulations issue, and that's available online too. You could just Google that. What are guidelines related to healthcare visitation policies? So again, I did a deep dive on visitation policies. The state has not really released any updates more recently than February. And the February was a letter from the health officer, the state health officer, which referred both to AFLs from 2020, which have been updated multiple times, and also just created some nice documents like this flyer, which really gets everybody on the same page about what is required for visitations in hospitals. So again, hospitals in all counties are to allow all patients to have up to 2 visitors from the same household at the same time, provided physical distancing can be accomplished and visitors comply with hospital visitor guidelines. So here's basically the list of patients that the list of patient groups that can get up to 2 visitors or support persons, and they don't necessarily have to be from the same household, and they don't need to be designated in advance. So, you know, you have lots of patients that fit under this criteria, including pediatric patients, LND patients, terminal patients at the end of life, which again is, you know, it's a judgment call. To some extent, all of us are terminal, but, you know, I think it really is a judgment call how soon at the end of life someone is. But basically, that is a category of patient that really where you can have more visitors. Patients with physical, intellectual, and or developmental disabilities, and patients with cognitive impairments, and surgery patients. Again, 2 visitors should be permitted until the patient is taken into preparation for the surgery. you can read a lot more at these links that I've provided. And these are nice flyers where you can really just put them up in big posters all over your hospital so that people understand what the rules and regulations are related to visitations. We know this is causing a lot of frustration. I wish it was easier, but right now this is all that hospitals are allowed to do. And to some extent other facilities and clinics, including skilled nursing facilities. All of that is addressed in these links. So please go back and review those and work with your teams to create a policy that's consistent, fair, makes sense, and doesn't drive you and your staff crazy. Hopefully you can figure out something that fits all of those boxes. And there's a whole bunch of resources, including FAQs and flyers, and the actual health officer order available at those links. All right, let's talk about vaccines and boosters. So the big announcement since the last time we met was that a second booster was approved by the FDA and then quickly supported by the Western States Scientific Committee, which really covers California. And so whenever the Western states approved the FDA's decision, that basically rolled over into the policy applying to California. And I think this is a nice summary of where we are. So we're going to go through what people with normal immune systems can expect and what people with immunocompromised can expect. So we'll do the normal immune systems first. So broken up by age, 5 to 11, what's really recommended at this point is 2 doses of the mRNA Pfizer product. If they're 12 and over, then they can choose the Pfizer product and get 2 doses, and then 5 months later get a first booster. And that is recommended in everyone. If they're 18 and over and they want Moderna, same thing, 2 doses and then the first booster 5 months later. If they have Johnson & Johnson, they really should get after their first dose, which is the complete immunization with Johnson & Johnson, 2 months later, they should get their first booster. So that's everyone. Everyone should get 2 doses and a booster. Hopefully that makes sense. And then there's some folks that need to get a second booster. And that is folks that are 50 and over, and those that are immunocompromised, which is shown in this table. So again, we just went through all of these blue dots and boxes. And then after you had your first booster, should you get a second booster? If you're immunocompromised, ages 12 and greater, you can get a second booster of the Pfizer. If you're 18 and over, you can get a second booster of your Moderna. And like I said, if you're not immunocompromised, but over age 50, then you should also get a second booster. So again, immunocompromised under age 50, or anyone over age 50 should get a second booster. And by should, it's basically a recommendation, but a strong recommendation depending on how many comorbid conditions someone has, or how risk averse they are, or how high risk their occupation is. So all of those should be factors in getting a second booster. You're going to hear opinions all over the spectrum that it's not really that necessary because we don't have enough data. This is really data based on one country's experience, the Israeli experience, that showed that the first booster immunity wanes after 4 to 6 months. However, there's other people that are saying, obviously these vaccines are showing waning immunity. Every time we check, we see waning immunity at 4 to 6 months. So it makes total sense that we should basically offer a second booster to people just to get them fully protected and everything in between. So I'm not going to be able to adjudicate for every single scenario. I would say, do a risk assessment and a risk benefit conversation with your patients and just let them know that this is available. If they are a high risk patient or they meet one of these criteria, that they should get their second booster. Then again, if they're not that worried about it, if they're lower risk or they've had COVID recently, then they might get by with just the immunity that they have already, and they may not need to get this second booster. Now, what about healthcare workers? Because we know healthcare workers are required to have a vaccine and they're required to have at least 1 booster. That's the law that the state health officer put out there. Are they required to get a second booster as well? Well, the answer is no, not right now. The health officer order to get 1 booster has not changed. That's still on the books. If you're a healthcare worker, you have to have at least your 2 doses and a booster, provided you're getting an mRNA vaccine, but you don't necessarily have to get a second booster. That's not yet required. I haven't even heard that it's in the plans or in the works. So it'll basically be a longer conversation. And I'm sure the state will give us a heads up if they're going in that direction, but they have not made any indications that that's being considered right now. And here's the summary of recommendations, because I know that was a lot to internalize, but this is a nice summary that you can read through or post or share with your staff if they have any questions. All of this is taken from this link right here, which is the CDPH fact sheet on vaccinations. All right, let's talk about COVID treatments. So as you know, COVID treatments are one of the real silver linings that came through during this last Omicron surge. It really didn't help prevent the Omicron surge as we experienced it, but I really think this is going to save us from having massive surges in the future if we know what we're doing and if we use these medications the way that they're being indicated per the NIH guidelines. So right now, per CDPH, we are really in the salad days in terms of the supply of COVID-19 therapeutics. We have a lot of therapeutics, and they've really opened up the floodgates to say all outpatients with mild to moderate COVID-19 should be offered treatment with one of these treatments. And I'll explain which one of these treatments they should get. But this is really different than where we were just a month ago, where we said, you know, only if they're 65 and over, or they have immunocompromising conditions or some other comorbid conditions, or they're high risk, et cetera. Now we're saying anyone come and get it. This is really keeping people out of the hospital. And as long as people need it, as long as they fit the criteria and as long as they understand the risks and benefits, et cetera, they really should be offered these medications, which is fantastic. This is really a sea change. And I think, like I said, as long as the supply keeps up, we can really prevent future surges from happening. Let me skip down a page because I think this is the summary that I wanted to share. So basically, let's break it up into, you know, not exposed, exposed, and then they are actually sick. So suppose they're an ill contact and you need to give them pre-exposure prophylaxis. Well, you can do that. Pre-exposure prophylaxis means that even before they're a close contact, they're just at higher risk. That's when you give them Evusheld. If they're basically immunocompromised, then Evusheld is a great medication. That's what you should give them as an outpatient. If they're a close contact, meaning they've been exposed to someone with COVID, right now there's no authorized treatments. There used to be, however, with these variants, they just don't work very well. We used to give post-exposure prophylaxis with monoclonal antibodies. We're not doing that right now. Then you move into people that are actually sick with COVID, but it's very early in their course. They have mild to moderate illness. They're still walking, they're talking, they're ambulatory, their O2 sats are normal, their x-rays don't look that bad. Basically, they can handle this at home, but they need a little bit of help just because of their higher risk condition. These are the folks that need to get monoclonal antibodies or antivirals. And this is the order of preference. So first, you should consider them for this bebtelovimab. This is the only monoclonal antibody that's right now indicated, given the fact that we have the BA.2 variant circulating. This is where we need to be. We're not giving sotrovimab anymore. You can forget about all the other monoclonal antibodies that we used to talk about. The only one is the bebtelovimab, and that is the one that the state is helping us distribute, and that's the one that our infusion sites have access to. If they're not able to get the monoclonal antibodies, they can still get the antivirals. They can get Paxlovid, which is an oral medication. It's really great, although it has a lot of drug-drug interactions, remember. They can also get remdesivir, which is IV, not a lot of drug interactions, but it does require a 3-day infusion. So remember that. And if none of those is a good option, then they can also go for molnupiravir, also known as Lagevrio, which is another oral medication, not as effective as Paxlovid, but still pretty good and very few drug interactions, although it has some fertility effects. So you want to have that conversation about using some kind of contraceptive while this person is on medications. And it can be up to 3 to 4 months if they're a gentleman. It's only a few days if it's a female. Okay, so in order of preference, again, the NIH has a little bit different order of preference, but here's what I would do. I would say do Paxlovid first because it's oral, it's easy to pick up. A lot of pharmacies now carry it. If they can't get that, then you can do remdesivir. If they can't get remdesivir, then you can use bebtelovimab. And if they can't get that, then you can use molnupiravir. This is from the NIH. The NIH is doing a great job updating these guidelines, making sure that they really respond to what's going on with the variants. And they have lots and lots of references and documents that back up this recommendation that you can find at this bottom link here. The top link is the CDPH guideline, which is where I got this top right graph. Okay, so hopefully that's clear. We have a lot of medications. You should be comfortable using them or prescribing them. If you need help locating them, then here's the testing locator. This is really something you should have on speed dial or bookmarked on your websites. It's www.covid.gov. And just for grins, let's just go there, and we will see where that takes us. So this COVID locator is basically covid.gov. Find COVID-19 guidance in your community. So let me share my other screen. And this is what it looks like. Then we just search for our county. But before we do that, let me just show you, this is where you can get a mask. This is where you can get vaccine information, treatment information, and testing information, including free take-home tests. So there's a lot of programs that the federal government is now working on, and all of these are located on this website. So now if you want to go to treatments, you just go click this find a test to treat location near you. And then it'll basically take you to this map that's maintained by the federal government. And then you just put in the zip code. So suppose we need 93706. And right there, it shows you, if you're in the 93706 zip code, how to access medications, as well as the test to treat sites. So here's where you can actually get a test to treat, meaning you can walk into the CVS store, they will do a quick test, and if the test comes back positive, they will be able to offer you a medication to help with your COVID diagnosis. If you just have a patient that you've already tested them and you just need to send them to go fill a prescription, then you can find locations to fill a prescription, and all of these locations are listed here too, in the order of how close they are to 93706. So hopefully that's pretty easy to use. I think this is a really snazzy website. They keep it up to date every day, and they tell you exactly which therapeutic is available. Like this Rite Aid has Paxlovid, this Rite Aid has molnupiravir, this Walgreens has molnupiravir, and it gives you the location and the map as well. So hopefully this is something that all medical providers can feel comfortable doing, and all patients can start to use themselves, so that they can start to self-refer to these test to treat sites. Again, it's the covid.gov, but then this site is also hyperlinked for you whenever you open up the notes, and hopefully you can keep that in a handy place. Let me go back to the other document. All right, so we talked about orals, we talked about Evusheld. Again, it's highly underutilized. Please help me think of solutions for this. Please, if you have any ideas, if you have any ways to really get Evusheld to immunocompromised patients, let me know. We have a team that's ready to help you, but we do need our medical community to step up, especially those of you that are seeing immunocompromised patients. We really need you to do some thinking outside the box to say, how can we make this happen? It may be as easy as just signing up for the HPOP registration and then just becoming a provider. And then you just start giving it every time you have an appointment with your immunocompromised patient, so that you can keep them protected for 6 months at a time. Ivermectin, still not effective. There was actually a trial that was done, not in the US, it was done in multiple countries outside of the US, but it was a well-done trial. It was published in New England Journal. It showed that it was not effective at all. And so this just hopefully is another nail in the coffin for ivermectin. It probably won't convince everybody, but hopefully it will convince all of you to stop using it if you had any doubts. It's just not effective, and it distracts you and the patient from accessing medications that do work, which is all the stuff that I just talked about. Dr. Zweifler has been doing great maintaining a list of recommended treatments and where to find them locally, and that's hyperlinked here. So please look at that. And that basically includes all the information about sotrovimab now being paused and other great links to local resources and information. So please take a look at that. And then the Federal Test to Treat site is located here in item F. This is a nice flyer for the free monoclonal antibody therapy. And then another nice flyer for the Evusheld developed by our partners at the UCSF Fresno COVID Equity Project. Again, this is a really easy option for your patients that need Evusheld. Just have them contact the COVID Equity Project and set up an appointment, and they can basically get put into the queue to get the Evusheld next time they offer it. So thank you very much to Dr. Bond and Dr. Dillon and all of our great partners that are doing this. We really appreciate it. We just need more of our providers to know about it and really funnel patients to them or figure out some other way to get it to our patients. And finally, I don't know if you knew this, but it's actually National Public Health Week. So I just want to say special thanks to my own team. I feel so lucky to have the chance to work with amazing people that work tirelessly to make Fresno County healthier, stronger, and safer each and every day. You can learn more about National Public Health Week at this link. And you can see there's just a lot of other things besides COVID that public health involves and things that we are working on, if not behind the scenes, then perhaps under the headlines that COVID always seems to get. But just keep in mind that there's a lot of non-COVID stuff that really public health is responsible for and that we would love to partner with all of you on. So hopefully in the future, as things get more normal or as we reach the next normal and get out of this pandemic and into the endemic stage, we will be touching on these other issues that are just also super important to keep Fresno County healthy. But nonetheless, it is a time to pause and celebrate and reflect. And hopefully you can thank your public health partners for all the great work that they do each and every day. And that's really all the formal comments that I have. I'm happy to take questions from the chat, or if you want to unmute and ask questions, I'm happy to hear from you as well. So the first question is, do you think it will be approved for healthcare providers to get the 4th shot, or is it only going to stay 50 and over? You know, I mean, honestly, no one is really tracking it that closely. So if you're a healthcare provider that's super concerned because you are, you know, in a comorbid condition that makes you relatively immunocompromised, then I think you can go ahead and get the 4th shot. I don't know that they're going to change the language of the 50 and over very soon. I haven't heard any indications that that's going to happen. But if you're under 50 and you're just worried and you just want to be extra protected, then you can go ahead and get it. I mean, I think they've really proven to be very safe and effective products. And really, I think no one's going to fault you if you want to go ahead and get that extra shot. I don't know if you read this story, but there's a guy in Europe, a little bit of a Looney Tune, but he was basically faking vaccination cards and selling them. And he ended up getting like 90 inoculations. He got 90 doses of the mRNA vaccine. He just went over and over again just to get the cards. But he basically had no symptoms at all and no bad outcome from getting 90 doses of the mRNA vaccine. So for what it's worth, it's just, even though it's just a single case report, it just speaks to the extraordinary safety of these vaccines. And really a 4th dose is going to be just as well tolerated as the first 3 doses. So provided that the person did pretty well with those, I think they can go ahead and get the 4th dose. I mean, we're already giving it to our more vulnerable patient population. So I think our healthcare providers that want it can go ahead and get it. I don't know that it'll be required. Again, I haven't heard that it will be. I think if things change with the metrics, or if there's more of a surge situation and we have a lot of healthcare workers falling sick despite having 3 shots, then you're going to start hearing some language or hearing some conversations that we're going to require a fourth shot. But provided that that doesn't happen, I think it's going to be really hard to get a fourth shot mandated. I just don't see that happening in the current climate that we're in.
Dr. Vohra, Dr. Baz here, quick question. I read that person also too. Do you have any other more information about that person? It's a very interesting case. What's her blood serology is, what kind of medical problem he has it, or anything like that. How old is he? Any information?
No, I haven't seen a formal case report about it. I've only read the headlines. And so I don't know that that they've done a real good investigation into that. But yeah, that sounds like, I'd be very curious too to see what his antibodies are doing.
The reason I'm saying it,
the immune system probably just saturates and then just stop making new antibodies in response, right? Because those antibodies are already around. So I'm not sure that he was really changing his immune landscape that much after the first few doses, and then it was basically just just the excipients or whatnot.
the reason I'm saying is if he really got all, so he did got those 90 shots, that we know, but if he really does not have any long-term or short-term side effect, it's very easy to convince the patient that, hey, listen, 4 doses is okay, that somebody got 90 shot and nothing happened. When you get the real life example, it works a lot better.
He actually, as much as he was helping the anti-vaxxers, I think he was really helping the vaxxers as well, because he basically proved how safe things are.
Yes. Thank you.
Sure, thank you. All right, any other comments? I got a few more in the chat here that I was going to address. Dr. Mitchell says partnering with local pharmacies for Evusheld. Yeah, that would be great. Great idea. I think that's really a good way to proceed. Do we have a time frame for a new surge or uptick? You know, we really don't. I think, the way that I'm looking at this is we're going to see this happen in phases, and it will go from a phase of rapid decline to a not so rapid decline to a plateau to then things going up the other direction. So I think what we're actually looking for is not an upsurge right now. We're just seeing whether this rapid decline, which is still happening, is slowing down at all. In some jurisdictions it is, in other jurisdictions it's not. For example, San Francisco is actually, getting a little bit more cases than the rest of the state. Obviously, parts of the Northeast and other countries are also seeing this BA2 variant really causing a lot of upticks. So it could certainly happen in the Central Valley here, but there's a lot of other countries and jurisdictions that aren't seeing the same thing. So I think it's really unpredictable exactly if and when this is going to happen. I think it is going to happen to us sooner or later. I just don't have a good time frame for when it might. So we're still just doing kind of anticipatory observation and just waiting for that indication. I think we're doing the best that we can, looking at our numbers, looking at our wastewater, looking at what our neighboring counties are doing, seeing state trends. So I think that's the best we can all hope for. And like I said, I think all of us have some homework to do in terms of preparation and just making sure that we're ready whenever that day comes, that we're now dealing with another start of another surge. And really just referring all of our patients as early as possible to get these medications and keeping our immunocompromised patients protected with Evusheld. That's really going to keep the next surge at bay. I mean, the next surge will only happen if we fail to do these things. But if we succeed, then it will happen in a very small fashion or never.
Dr. Vohra, a couple of questions. One, by any chance, do you know what's happening in Shanghai? What variant is that? Because that's causing massive problems.
I believe that's the BA2 variant.
BA2 variant. And second thing is, as you mentioned, Evusheld we are giving to the patient, but we have to give double the dose. By any chance, do you know when we can get 300 milligram instead of 150? This way we are giving 4 shots rather than
Let
2.
me ask about that. That's a good question. Certainly something we can elevate to the CDPH therapeutics team. So right now you're giving 300 or you're giving?
No, because CDC recommendation is give 300. Actually, I just saw the notice, I think came from your county office also too, that the people who got 150, they need to be called back and give another 150.
Okay.
Remember, they come 2 separate antibodies, 150, 150 each. So now it becomes 400 IM. So 2 shots, 300, so we have to give it. That's number one. And one of the other thing, if you can do it, lot of physician and community do not know much about Evusheld. And I'm shocked so much because when I talk to them, of course, our office is familiar with it. And if you somehow can educate the primary care, because those are the ones really needs it. It's an IM, they can give it to themselves. If not, of course, we'll give it to them. But ideally, they can give it to themselves. It's not that difficult to do it.
Yeah. Yeah, no, I completely agree. Yeah, I would love to partner with you, Dr. Boz, to do some kind of a CME or some kind of an outreach to our primary care community. But it really is all up to all of us to spread this information throughout our networks. I think the other barrier, which is somewhat harder for us to solve locally, is this requirement to register into a website called the HPAP.
Yeah.
And that is just a big pain in the butt. And I understand why doctors just give up. They're just like, I don't have to do this. This is much harder than it should be. And so they just give up. And unfortunately, you know, at the state and federal level, there's really no momentum to make that easier. And so that's why we have these workarounds. You know, we have partners that accept Evusheld because they are part of the HPOP website. For example, CRMC is a great partner. And then they basically pass on the Evusheld to other facilities that are not HPOP websites, or that are not part of the HPOP registration, just so that we can distribute the Evusheld. So, you know, it's complicated and it's hard to scale up, but that's kind of the logistical barrier that we're working against. Beyond that, it's really, like you said, it's really disappointing that more primary care doctors and more general providers don't know about this Evusheld, because it's a game changer. I mean, you know, it's like during the Omicron surge, I was like, I wish I could have it, you know, but I'm not immunocompromised, so I don't qualify. But this is like, you can protect patients for 6 months at a time. It's a really good medication that's just flying under the radar. And at the same time, immunocompromised patients are having trouble accessing sites that offer it. So the opposite is also true, that some patients just don't know where to go.
Some of us who are senior citizens like myself, we do qualify. So, but anyway, I think we should get the education to the primary care. I think it's very important. I do on limited scale when I meet them.
Okay.
My biggest shock is they don't even know the name. They never heard about it. They don't know what it is. And I have to literally spell it and write it for them. So that's, I was shocked to hear that.
And I think I like what you said, that it's an injection, not an infusion. So it's like getting a vaccine. You come in, you get a quick injection, there's a little bit of a monitoring period, and then you're out the door. It's a very easy appointment.
Thank you.
Thank you. Chris is asking, do boosters have the same formulation and ingredients? And as far as I know, yes. I mean, obviously, these pharmaceutical companies and the researchers are under a lot of pressure to create products that are responsive to these newer variants. But from what I can tell, these are still the same products that have always been around. They still are pretty good, even though they're not as good as they used to be to cover the newer variants. They were really good against Alpha and Delta. They're still pretty good against Omicron, and it's just a matter of time before that effectiveness wanes so much that we no longer recommend vaccines. But right now, the vaccine shield is still holding, and that's why it's important to get people boosted, because we know that that will protect them against future infection with the variants that we have currently. So hopefully that answers your question, Chris.
Yeah, thank you.
Sure. Colleen's asking, do you have an update on the health emergency order that's set to expire on 4/16? I really don't. I'm sorry. I can look that up. It sounds like it covers telehealth, but I'll see if they are planning to extend that or sunset or what. If you want to talk offline, Colleen, I'm happy to talk to you about it. Otherwise, I'll try to figure out where that order is going to be and what the implications will be. And next time we meet, I'll definitely comment on that. Any idea when the vaccine mandate in healthcare will end, or will it ever end? I think it's too early, Maria. I think that's a great question. I think it's entirely too early to make any judgments about that. I mean, for example, we have the flu vaccine mandate a year after year. So this might become one of those where if we figure out a seasonal pattern, then we will basically have an annual mandate for this. No one's really talking about ending this vaccine mandate just because I think everyone is still just recovering from the surges and the many disruptions that COVID itself has caused in healthcare. So I'm not sure that the vaccine mandate will end anytime soon. No one's even talking about what criteria will be in place whenever people start talking about ending the vaccine mandate for healthcare. So I think it's here to stay for the time being. There's a question about the community transmission and how Fresno is in the high, and whether that's because of a lag in data and why that's happening. Yeah, it's interesting. It depends on, I'm not sure exactly which website you're looking at. The CDC maintains a website which has a slightly different criteria in terms of case dates and case rates than the state websites. And so we hover in the medium to high range. I think that is coming down, but like I said, relative to the rest of the state, and especially for counties our size, we actually have pretty high numbers. I mean, we're number 6 in the state for the number of cases in our hospitals, but we only have 1 out of 40 million Californians. And so it's just kind of interesting that we're a relatively high compared to the rest of the state. And whenever people set these metrics, they really need the metrics to be very, very low before they call it low or medium. And so that's why we end up being in the high category, even though it feels like things are better for us. It's still not normal to have, hundreds of positive cases a day or 60 cases in the hospitals. That's still considered, some level of transmission. Hopefully it's going down, but that may be why it's considered high. But I would need to see the actual website before I give you a more specific answer. And then Dr. Z has a really good update about Dr. Al Sagbini talking about management of drug-resistant organisms and the carbapenem-resistant Acinetobacter. And he's going to be talking next Tuesday, April 12th, from 10:30 to 11. And we can hopefully share out that flyer. If you haven't seen it already, you should have gotten it in your email because I know we circulated it to all of the medical providers that are on this call. So hopefully you saw that. Dr. Al is such a great resource and he has so much knowledge to share. And this is a super important topic. Talk about something that's really going to disrupt healthcare. Drug-resistant organisms are here to stay. So even if COVID was totally gone and in our rearview mirror, this would be something that we would continue to talk about and would need to educate everybody about. So please tune into this because this is really something that will affect your practice. It will affect your patients. It will affect all of our healthcare facilities moving forward. And it's not too early to learn about this. Even as we're still talking about COVID, we have these other issues in infectious disease that we need to talk about. And then someone's asking, can the second booster be either Pfizer or Moderna if you receive Pfizer for the first 3 shots? Yeah, I think that's fine. Other countries are definitely more explicit about this. The US wants people to kind of stay in their lane. But at this point, I think lots of people have done mixing and matching. The shot that's first available to you whenever you're ready to get it is the one that you should get. And if it means that you're switching from Pfizer to Moderna or vice versa, that's totally fine. There haven't been any interactions that show that that's not a good idea. These are great questions. Thank you. All right. Well, are there any other updates? Any other questions, comments, suggestions? Thank you all so much. This was a great call. I know that we're coming up on the hour, but happy to stay on and answer any other questions or hear from you if you have any other comments. All right, we will send out a revised version of these notes if you're interested. And hope to see you again in a couple of weeks, and we will continue the conversation then. Thank you so much. Take care.